Awesome. Hi, everybody. Thank you so much for joining us this evening. I am so excited to have Diane with us this evening to talk about high resolution pharyngeal manometry. My name is Brooke. I'm a speech pathologist here with Tim's. A couple of housekeeping items before we get started. This webinar is being offered for zero point 0.2 ASHA CEUs or 2 PDHs. If you would like ASHA CEUs for this presentation, we ask that you stay for the entire duration of the session and that you complete a brief survey within 7 days of course conclusion. I will put the information about the survey in the chat. It'll also be sent out via email from Zoom at the end of this webinar. Additionally, if you'd like a certificate of completion, just send us an email at tims-univ@tims.com and we will get that back to you within 7 days. Finally, this presentation is being recorded and the replay will be up on the TIMS website within 48 hours. If you have questions as we go along, feel free to pop them in the chat or the Q&A box, and Diane will address those during the Q&A at the end of the webinar. With that, I'll go ahead and hand over the floor to Diane.
Perfect. Okay, good evening. I'm going to share my screen and then we'll get started. Let me share my screen. Okay. I'm going to make sure you can see my screen and not my notes. I'm going to switch this really quick. Okay, let me make this smaller. Okay, I think you should be able to see my screen, not my PowerPoint now, I think. Let me know
Yes.
if not. Okay,
Perfect.
perfect. Well, thanks for spending your evening with me. My name is Diane Longnecker. I actually am as of about a year ago, an assistant professor at Baylor University, which is a big university in Waco, Texas. And I'm really excited to come talk about this. I did a lot of my dissertation work on clinical utility and implementation of high resolution pharyngeal manometry. I also prior to all my PhD work, actually was able to work with a team of people at my I still hold a clinical placement at Baylor Scott and White, which is a big non-for-profit hospital system in Texas, if you're not familiar. And I was fortunate enough to be able to start a pharyngeal manometry program there. And so I'm glad to be able to share this with you. I hope that it's helpful clinically for those of you guys that are interested in pharyngeal manometry. And that's a little bit about me. So I do get an honorarium from TIMS today, so I do want to disclose that. And I also get salary from Baylor University. So we're going to go through sort of the nuts and bolts of high resolution pharyngeal manometry. I also can't do a pharyngeal manometry talk without discussing the upper esophageal sphincter and the anatomy and how that works, because manometry is a really beneficial tool for assessment of that. And so we're going to talk a little bit about that, and then we'll talk about some benefits of manometry, some barriers that I know you guys either are not aware of or you are aware of, and I'll talk through sort of how we worked through some of those solutions when we started the program in Texas. And that's sort of the agenda for tonight. We're going to go just shy of 2 hours probably. Okay, I'm going to open this chat so I can see it in case there's questions that I should answer as we go. I don't want to like leave people hanging. Okay, perfect. Just make sure you can see me. All right, so I think before we even begin getting into like the nitty-gritties of pharyngeal manometry, we should probably start with what manometry is in general. So manometry, that word is not unique to swallowing. It's not unique to pharyngeal manometry. It's not unique to esophageal manometry. The word manometry is really just the measurement of pressure a device called a manometer. Okay. So we have some manometry that's probably more familiar to you, even as a speech pathologist, than pharyngeal manometry or esophageal manometry is. We have this is a manometer. Okay. I hope you guys recognize that as a blood pressure cuff, right? So it is measuring pressure, that then gives us a blood pressure. This is a manometer. This is a type of manometer. This is, if you're not familiar, this would be like what you would measure a cuff with, like a tracheostomy tube cuff or an ET tube cuff. Um, that's a manometer. This is also considered a manometer. So this is something that might measure expiratory strength or the pressure, expiratory strength or expiratory pressures, right? Or inspiratory if you use it that way too. So this is a manometer as well. And so manometers are not, and manometry are not unique to swallowing. Um, but I do want to give a little history on how manometry and swallowing began, because I think unless you sort of know its journey, it's really hard to appreciate where we are now with it. We have to start way back before probably, well, I know for a fact any of us were born. So back in the 1880s is really when esophageal testing was first introduced for the first time. Okay, so really what they would make the patient do is they make the patient swallow a series of small balloons that were connected by tubes. And then those tubes would change based upon how the esophagus was behaving, and they would be connected to a tube outside the body too, right? And so that was sort of the first crude attempt at understanding how the esophagus worked through some sort of manometry pressure-based reading. I will say that crude sort of balloon tubing system that was first started in the 1800s didn't have a lot of attention spent on it for a good number of years, because for probably the next 50 years after that, a lot of energy in esophageal medicine was really put towards the X-ray and exploring the use of the X-ray to assess esophageal function. And so manometry, while originally started in the 1800s, really didn't pick up much speed for quite some time. Well, you fast forward to the 1950s. So the 1950s is when we first introduced what they call conventional esophageal manometry. And so that's where there were water-filled tubes placed down into the esophagus and measured changes in the esophageal pressure. That is different than back in the 1800s when they had balloons and tubing connecting the balloons. This was definitely an advancement from that, but these were water-filled catheters. Okay, that was in the 50s. Once things sort of got more traction, more attention was put back into esophageal testing other than the X-ray. Then in the 70s, that was what most people would say is our first attempt or our first high fidelity conventional esophageal manometry. High fidelity meaning it actually yielded information that was really beneficial to the evaluation and management of esophageal motility disorders. So it really refined how we use these water-filled tubes, and it gave us standardized data in the 70s. It also began to teach us how to interpret the data that we were getting out of it. And actually, that type of manometry remained standard for esophageal manometry for nearly 20 years until high resolution esophageal manometry was developed. Okay. Well, that high resolution esophageal manometry was developed and introduced into clinical practice really in the early 2000s. I would say during the 1990s and early 2000s, as high resolution esophageal manometry was beginning to be used, that was when the conventional manometry that was sort of fading out for the esophagus as this high resolution came in. That's when the conventional manometry began to be used to collect pharyngeal function. Okay, so in the 90s and the early 2000s, that's sort of the first time that we used that technology to begin to understand how the pharynx was working as well. I will say at that point, we really didn't have any normative data on the pharyngeal function using this modality, and it really was not being used clinically in the pharynx at that point. Now, fast forward to 2011, many of you guys, I would think, were definitely born, and I would hope many of you were practicing at this point. 2011 was really the first time high resolution pharyngeal manometry with impedance was introduced into clinical practice. It at this point was sort of a novel method of non-radiologic assessment of pharyngeal swallow function using manometry plus impedance that you're going to learn about today. And it was shown to be able to predict dysphagia. So now we're beginning to like pick sort of I guess shorten the gap, right? Like fill the gap between what has been used in the esophagus for some time now, but coming into the pharyngeal space as well. And then there's actually there's definitely been more since 2020, but I would say 2020 was a pretty um, critical sort of turning point in the clinical utility of pharyngeal manometry, in that it was the first expert consensus publication on how pharyngeal manometry could be clinically used. And the goal of that consensus project and publication was to aid in the translation and the adoption of high resolution pharyngeal manometry into clinical practice. And since then, there's been more publications. There's been even as of less than a year ago, there's sort of frameworks for diagnoses, and a lot has come out on the clinical utility and trying to understand how this modality potentially could be used in a clinical setting. And so that's sort of the history of manometry. You know, not unlike anything else, right? Like speech pathology tends to sort of follow behind other specialties. So manometry, while new in our field, relatively new in our field, has been around for quite some time in the esophagus and the esophageal space. And we're just sort of figuring out how that applies into the pharynx at this point. All right. So I want to tell you a little bit. I know these virtual classes are so hard because what I really appreciate about in-person classes, I get to understand a little bit about what you guys do, what settings you work in, what your exposure to pharyngeal manometry is. I sort of presume, just based on anecdotally what I know about our field's utility of manometry, I bet a lot of you guys have heard of it, potentially aren't using it, or don't even know where to begin. And then maybe there's some of you guys that are using it consistently and very well versed in it. And so for those of you that are new to it or considering use of it, I felt like it might be beneficial to tell you the story on and the players involved in how we got it started in our facility. So the first thing I want to tell you is this got started well before any of my PhD studies. So I will say, for those of you that don't have a PhD, you don't need one to start a program like this. And I sort of hope that that empowers you, that if this is something you want to do, it's very possible to do that with the right partnerships and collaborations. I led the start of this in a big hospital system here in Texas well before I went back to school. So here were the big players, and I'll tell you how this worked. So I was on full-time faculty at Baylor Scott and White, which is a big hospital system. It's kind of a hub and spoke hospital system. I worked out of the Dallas hospital, which is the hub of the hub and spoke. It is a major medical center, has every specialty you could ever want, ambulatory services, inpatient services, the entire continuum. And we have still a big Center for Esophageal Diseases, and they're some of the providers you see down on the far left. So they are GI physicians that have done extra fellowship in the esophagus, a lot of them in Chicago, not all of them, but a lot of them. And while they are GI doctors, they only do esophagus work. They do research on the esophagus, they do evaluation, they do treatment, they manage it, all the things. So we have that group of people. And then we have a whole host of laryngologists that staff what we call Baylor Scott and White, the Voice Center out of Dallas. You can see those ladies in the top right. Fellow trained laryngologist, really interested in voice, but also swallowing. And I was staffing an outpatient outpatient modified barium swallow study clinic for these ladies and men. And they would send all of their modified barium swallow studies into me as a clinician. And so initially we met and had this relationship develop truly out of they were sending their referrals into my swallow study clinic. And then over the years, we then began to establish weekly dysphagia rounds where the GI team, the laryngology team, plus a lot of our surgery teams that help manage these very complicated dysphagia patients, like cardiothoracic surgery, minimally invasive surgery, our radiologists, speech pathologists, we would all come together and talk weekly about sort of particularly interesting or challenging dysphagia cases. So that's where it really began, right? It began there in like building the rapport as like just clinicians that are trying to do the best, that have a unified interest in swallowing, wanting to do the best for their patients. Well, we also found very quickly what I think I underestimated this before I had such a like core relationship with particularly our GI physicians, is that I think we underestimate how similar we are actually in our methods or what we should be using as our methods for assessment. So what we very quickly came to understand is that if we're all interested in dysphagia, we all came to the agreement that a thorough evaluation of dysphagia, while speech pathology looks at it from a diet standpoint, right? And yes, that is part of what our evaluation does. The vast majority of the patients that we as a team, between the laryngologist, the GI, and the speech pathology team we're managing, were a lot of cases where the diet wasn't the concern, right? The concern was trying to determine the cause of their dysfunction or the cause of their complaints, and then guide appropriate diagnosis of that. And then that leads to appropriate referrals, that leads to appropriate treatment planning, right? Because I think what we very quickly realized is, you know, speech pathology could probably learn a lot from GI, right? We know we can learn a lot from our GI counterparts in that, GI oftentimes will utilize endoscopy and fluoroscopy and manometry to triangulate the findings in the esophagus to get an accurate diagnosis, really understand the cause of the dysfunction, and appropriately make referrals and treatment plans, right? Well, speech pathology oftentimes doesn't, or I didn't at the time, and I sort of anecdotally suspect a lot of times speech pathology doesn't have a full appreciation of how we can use different modalities to triangulate information about a single patient to guide treatment planning, right? So GI has all of these resources available to them. Well, we as well, right? So we also have endoscopy, we also have fluoroscopy, and then what we're talking about today is we also have manometry. And while some cases you may get enough information, um, to guide your treatment plan off of one evaluation technique, there's a good chance that there are cases that you've run across where actually two or three modalities of evaluation would better let you determine the cause of dysfunction, guide appropriate diagnosis, and lead to appropriate referrals and treatment. So once we all came to this conclusion, it was kind of a no-brainer to our GI team. They were already doing manometry, and I essentially said, "Hey, can we try pharyngeal manometry? I know that you guys are using high-resolution esophageal manometry. Would you be willing and open to collaborate on trying this in the pharynx?" And they were like, "Absolutely." This was back in like 2018. And they were like, "Yeah, absolutely." Well, by the time we figured out logistics that we'll talk through today, COVID happened, and for a good amount of time, manometry in our facility at least was a aerosol generating procedure. And so, ambulatory use of it was sort of shut down for a good period of time, and it kind of halted the start of it. But once all that lifted, then we still had buy-in, and we were sort of given permission, and they were excited to collaborate on the start of this. Um, Here's where we began, right? Like, who did we try this on first? So one, I would tell you, manometry is not often needed for every single patient you see. We started doing manometry with those patients where after the modified barium swallow study or after the fees, we had remaining questions, right? It was a very complicated case, or the visual analysis or the images that we were able to visualize left us with questions. That was one type of patient. The other one was when we couldn't fully understand what the UES was doing. Why was the UES behaving in such a way? Was there UES dysfunction? So we started with those two big categories of patients where the MBS left us with more questions that needed answering with something that manometry might be able to answer. And so that's how we began it. It began, I think what I, as a clinician, until I started a big program like this, didn't have a full appreciation of was that you don't have to start and have hundreds of people run through these programs, right? Like it starts very small and steady, choosing patients wisely, learning the process, figuring it out, right? And this is how we started it. Okay, so now that you know sort of how and who was involved in the starting of a program, and actually who's involved in not just ours that we started, but also a lot of them, we now want to talk through what it is, right? The equipment, the procedure, all of the things, just to make sure that we know exactly, we're all talking the same language. So the first thing I would tell you is you do need equipment. The picture you see here is the Medtronic system. There are other companies. That's not the only company that makes equipment. You just happen to see that picture here. Labori makes equipment for this. Really, any solid state, high resolution manometry system will work for this. Um, Nowadays, so you remember in the history of esophageal manometry, I talked about these water perfused catheters. Well, we have gone beyond that now. Once we got to high resolution pharyngeal manometry, we were beyond water infused and we are now to what we call a solid state catheter, which there's not water in that tube. So it's far safer, right? To like pull a tube into the pharynx, it's not water filled. Um, it's a solid state catheter. You need a catheter that has at least 10 pressure sensors. And if your catheter is big enough and has the capability to do impedance, then you will have impedance electrodes spaced alternate of that. And so, again, this is Medtronics. I will say we use Medtronics, and I'll tell you why. It's because when we talk later about barriers for clinical utility of this, I think one of the barriers that everyone would acknowledge is the cost of this equipment. And getting access to the equipment can be kind of challenging. And our GI team was already using this equipment for esophageal manometry. And so it made the most sense to begin our program with this equipment, right? It was already there. We didn't have to purchase it. We were just essentially borrowing it for our cases. But all that to say, there are usually two different sizes of catheters. There's smaller catheters that tend to not have impedance on them. That would be something like this one on the left, where all these sensors you see going down this left one, those are pressure sensors. Okay. In contrast, you can get a bigger diameter catheter like this one, where you actually have gold. This gold one is an impedance um, sensor, and the copper one, I guess, would be your pressure sensors. And so you can see they're alternated sort of every centimeter for your copper and every 2 centimeters for your impedance. And so then you have the ability to capture all of that data in the bigger catheter. I will say the big catheter is probably about the size. I mean, it's 4.2 millimeters. You can see the sizes there, but like if I were to relate it to anything, it's kind of like an NG tube, maybe a tiny bit smaller than a normal board NG tube. So they're not small, but they're not the biggest things you've ever seen either. And so those are the two big things from an equipment standpoint you're going to need. You're going to need catheters and you're going to need an equipment, like a system of some sort to capture the data. This is Medtronics. There are other companies out there like Labori. Okay, I pulled this video actually years ago. It's not my video. It is like free public domain on YouTube, but I actually think that, and there's the site if you want to go find them. It actually does a nice job showing you how this is put in. Okay, so this catheter, what happens is the catheters are placed transnasally, so through the nose, down the pharynx, into the esophagus, very similar to like an NG tube. Okay, so I just want you to watch. There's no sound to this video. I'm going to talk over it just a little bit to orient you to what she's doing, but just watch her place this catheter. So she's lubricating it. That's the first thing, no different than you would endoscopy, like if you did fees or dropping an NG tube. She'll put some lubricant on it. And then you can see he's sitting upright. Now she's going to slowly advance this catheter down the floor of the nose, just like you would a laryngoscope if you're going in for voice or swallow a vowel with endoscopy. So she's going to advance it and she's going to feel a little bit of resistance at the VP port. And then she's going to push past that resistance and then she'll meet a second source of resistance. That's the UES or the piriform sinus. And then what she's going to do is hand him water and ask him to take a sip. And every time he swallows, the UES opens and she will advance that catheter down into the esophagus. Okay. Then she's going to look at her screen, and I'm going to show you what the screen will look like close up in a second. And she will confirm, based on the pattern on this screen, if this catheter was placed in the correct spot. So I will say, um, there is this discussion on do you do simultaneous fluoro to confirm placement or not. When you're new to it, I don't think that that's a bad idea. I will say experienced like placers, like have placed a lot, typically learn to place it without fluoro guidance, just for like sort of efficiency and workflow purposes. And the nice thing is we have an ability to confirm its placement based upon the readings of the data that you can see on the screen. So once that is in place, she will tape it. Okay, and it will be taped on the nose just like you would see with any sort of feeding tube that you might see. Okay, now you also have to let that catheter sit and you have to let the patient get comfortable. So you don't immediately start the procedure. You will set and wait, and the recommendation is at least 5 minutes to let the person accommodate to or acclimate to that tube that is now in place through the pharynx. All right, so here's some considerations. One of the things that tends to be sort of not a sticking point, but something that I think you have to work through from a process standpoint is who's going to place this catheter. Catheter placement does require education. It does require training. I will say in my facility, we already had uh, essentially medical techs that were trained by our GI lab to place these catheters, had competency signed off, had reps watched, right, had been trained with hands-on training and been deemed competent to place these catheters for esophageal manometry. And so they actually place them most frequently for us as well. But there are plenty of places, and we do sometimes have speech place this catheter as long as you've been trained appropriately, you have appropriate like compliant stuff in set for your facility. It passes, like I said, just like an NG tube through the nasal pharynx all the way down into the esophagus. Now, I will say some things to consider about placement of these types of catheters. Or manometry in general, right, is the patient really probably needs to be awake and alert and able to follow directions to some degree, because what you can see is we need the patient to swallow. And so we need them to follow some commands. And so sometimes mental status and cognitive status may be a limiting factor. I would say more frequently a limiting factor, or something that you really should be mindful specifically from a catheter placement standpoint, is any known pharyngeal or upper esophageal obstruction, like tumors, large Zinker's diverticulums, things like that, or any sinus surgeries, injuries, any sort of anatomy that may preclude you from getting the catheter safely through the nasal cavity as well. And so every now and again you run across that. You just need to be thoughtful from an anatomical standpoint. The nice thing about these types of catheters is they're not that much different than like an NG tube or a Dopphoff or something. So if the patient is a candidate for one of these, there's very likely they're a candidate for a catheter placement for this procedure as well. You would just want to double check all of that and talk with the physician. Okay, so once a catheter is placed, then you have to give them different trials of liquids and foods, potentially depending on the patient's performance, to get them to swallow during this procedure. Now, I'm going to show you a protocol. Anytime there's a protocol, I should say this, protocols are essentially a set of swallows to ensure that you get the minimum amount of information needed on any sort of test. And so modified barium swallow studies have protocols, fees typically have protocols. It's not that you can't do additional trials to these that are specific to that patient's presentation and needs. A protocol, especially like this one that I'm showing here, is really just to ensure that you get the minimum amount of information needed so that you get good data from this test. So the interesting thing you're going to see here, if you're new to manometry, is one, the liquids are saline. Okay, so saline is what allows you to get the impedance read. Okay, so liquids are saline, and then puddings, and then crackers of some sort. You do measure in very controlled boluses, and this is particularly important for this procedure because we have normative data. Okay. Um, and the norms, if you don't use the correct volume or the correct viscosity, you need to make sure that you use those so that you can compare to the norms that we have available out there. Okay. And so this is a minimum. If you want to put, sometimes people put 20 mLs in there. I actually do now most frequently put 20 mLs in there as well. So three 5 mLs, three 10 mLs, three 20 mLs. The other reason you would do three is because you are trying to make sure you have a consistent understanding of the swallow. And so you want to make sure that you are essentially taking um, averages and majority of swallows to try to make a determination. And so if you only have one swallow of one thing, you don't have enough information to really understand the swallow. It has some variability to it even when you don't have dysphagia, and has more variability to it when you do have dysphagia. And so you just have to be thoughtful to make sure that you run it under protocol with saline, pudding, crackers. Okay, so as you give these things to eat, this is what the screen looks like. I'm going to let it play for a second. So I want to orient you. The top sort of high pressure that you see here, when you're looking at this, blue or like cool colors like blues are low pressure, like atmospheric types of pressure, low. The more warm the color, the higher the pressure. Okay, so you have greens and yellows and oranges and reds. Those are higher than the blues. Okay, when you're looking at this, the way you can know when you place the catheter, if you're in the right spot, is you'll have two, really one, but oftentimes two high pressure zones. The one you always have is this high pressure zone that's running almost right down the middle of the screen. That is your upper esophageal sphincter. So if you know how that sphincter works, it's tonic or it's closed at rest, which means when the catheter is passed through it, you constantly have some pressure placed upon that catheter, and you will get a band of pressure just like this at the UES. The other place you oftentimes get a band of pressure because the catheter is sort of bent is when it goes through the VP port. And so this top one you see here is the velopharyngeal port. This one right here is the upper esophageal sphincter. So I want you to watch. So what happens is it captures it over time, just like this. And then you will give a bolus of whatever you're giving. So let's say we're on 5 ml of saline. And then when the patient swallows, you will see a swallow occur. A swallow looks just like this. And then you will not see a swallow any longer. And then you'll give them another something to drink, another bolus of your protocol. You will see another swallow and another swallow. This person actually swallowed twice on a single bolus, back to back, right? Swallow, swallow. You also see this down, kind of cascading down the screen. That's your esophageal propulsion. We're not analyzing that in the pharynx, but that is what you're seeing, that pressure wave go down the esophagus. And then you see this person swallows again, just like that. So this is how it's captured. It's actually captured live time while you're going. Now, you can make some really crude analysis of this as you're used to it, but the actual analysis happens post hoc, like happens after the study's done, because you can clearly tell, like, making sense of these colors requires like you to sit down at a computer and put some numbers to this. But it captures it just like this. So you can see when the patient is swallowing. These, if you're new to pharyngeal manometry, this is what you're looking at, okay? So the first thing you should know is over time, and the swallow doesn't happen while visually it kind of looks like it happens at a single moment. Actually, when you slow it down, the swallow happens in a cascade of events over a very short period of time, and that's what you're capturing here, okay? So what you're going to see is this big top part. This is your pharynx, okay? The pharynx can then be subdivided. No, not really any different than what we do in the modified barium swallow study, where you have a velopharyngeal segment, you have a meso. In pharyngeal manometry, it's called a mesopharynx, which is really your tongue-based region. So you'll have a tongue-based region, and then you'll have a hypopharyngeal region. Okay, so you'll have a pharynx that you can then subdivide into its spots. You then will see that you can see the UES opening, right? So the UES is tight or has resting pressure over to the left. And then when the swallow occurs, the pharynx will generate more pressure and the UES will open. That means the pressure will drop. You'll see more blues in the UES. And then as the swallow finishes, the UES will return to a closed position and then sort of go back to its steady state. So that is sort of to orient you to what you're looking at when you're looking at these pressure topography. Now, I will tell you, all of this really pretty color is actually in the background. It's a bunch of sensors giving you waves. They just put it in this kind of visual picture, which makes it a lot more clinically able to be utilized than potentially the waves, if that's all that we had. All right. So that is what you get. You put a catheter in, you ask them to swallow a series of boluses, some saline, some pudding, some crackers. You get pressure topography back just like this. Now, the question people always ask is, what can pharyngeal manometry assess in the swallow? What does manometry assess in the pharynx? I'm trying to conceptualize that, right? So it does really four big things, okay? It does pressure. Okay, so that catheter will give you pressure readings. Now, it does that in a couple different ways. What that's measuring is the pressure generated on the catheter at various parts of the swallow. So as things constrict upon that catheter in the throat, it will give you pressure. In this left picture you see right here, you can take your cursor and get a single number that says at this point right here, I have as much pressure, I have X pressure, right? If I had moved that cursor right there down into the UES where it's much bluer, then that would be a much lower number in the UES, right? Or even before the swallow happens at the same spot, right? The other way you can get pressure is you can take a box and you can say, okay, this is the entire pharynx, like we just talked about. I want to know the highest pressure in the pharynx and I want to know the lowest pressure in the pharynx. And so you can draw a box around your entire pharynx and then it will produce pressures, your minimum pressure and your maximum pressure. So it will give you pressure just like that. Okay. The other thing it gives you that is actually clinically very useful, and we do a lot of our analysis using this idea, is it can give you contractility. So some people think contractility and pressure are the same. Pressure is used in calculating contractility, but not the reverse. Okay. So contractility is essentially a measure to assess the vigor of contraction. Okay. So in pressure, I get 1 point, or I get a minimum or a maximum in that spot. But if I circle the entire pharynx, then I can actually get the vigor of contraction over space and time of the pharynx. And I get a very different number down here, and we have norms for these contractility numbers. Okay, so it's really looking at how well does the whole system contract over the period of time it's supposed to be contracting, right? So think about this, right? If you have a swallow that doesn't have as a high pressure, but it lasts a long time versus has really high pressure and doesn't last very long, there's some variability in the contractility, how vigorous that contraction is. This is what we divide into the different regions of the swallow. So we will get an entire pharynx contractility, which is what you see here. That's pharyngeal contractility. And then we can subdivide that into the velopharynx, the meso or the base of tongue region, and the hypopharynx so that I can really see, okay, if I have reduced overall pharyngeal contractility, what part of the swallow is causing that? Is it the velopharynx that's weak? Is it the base of tongue that's not contracting? Is it the hypopharynx that's not contracting? You're able to break it into its parts and really identify where the contractility issue lies. Okay, so pressure and contractility sometimes are confused, but manometry gives you both. It also gives you duration. Okay, so how long something is moving. Okay, the one that's the most clinically used in manometry is how long, for instance, you see in this picture, the UES is open, right? Is it open for a long time or is it open for a very short period of time? So manometry gives you duration, not just our visual perception of duration based upon bolus clearance, but a true number to duration. It is open X number of milliseconds. Okay, and we have norms for that. And then the final thing it can give you is something that I've alluded to a little bit, which is impedance. So impedance is essentially an electrical current. So when someone swallows salt water or saline, there is sort of electrical currents that run through that water and pass around the catheter that's in place, and it detects how the liquid is moving through the pharynx. Okay, so when you turn it on, what you can see is now I have the same pressure band that you were used to seeing, but I also have this blue or this purple overlay, and that is essentially showing me where the flow of the bolus is. So how well is it going through the UES? That's the biggest, the one that makes the most sense to most speech pathologists is this idea of max admittance. Okay, so UES has to let food through and essentially has to admit food into the esophagus. Okay. And impedance allows us to measure how easily liquid is flowing into the esophagus. Okay. So is it flowing without much resistance, or is there some source of resistance that is allowing the bolus not to flow in? That's what impedance does. So, you know, impedance is a very different measurement than the pressure, contractility, or duration is. Okay, so let me explain something because I feel like manometry, when you first learn about it, if you guys have, you know, have not looked at it much, I think sometimes your eyes can become crossed a little bit. And so I often think that one of the reasons manometry is a little bit hard for us to cerebrally understand when we're first learning it is that speech pathologists tend to be trained, which understandably so, in sort of we understand the swallow as a like mechanical system. Okay, so we understand the swallow as, your velopharynx comes back, meets your posterior pharyngeal wall, right? You get closure at the VP port. Your hyolaryngeal complex elevates and comes forward. Your epiglottis inverts. Right? You see it's very mechanical. Your UES opens and the bolus goes through and then it closes. Like a very mechanical sort of perception of the swallow, which is all very true. But I think what we don't appreciate as easily, and I think it just like takes some sort of thinking about it, is that actually the swallow is a valve and chamber system, and pressure plays a lot of role in this as well. Okay, so think about not the mechanics of the swallow, but think about how we form chambers in the pharynx when we swallow. So, you have your oral prep and oral transit phase, but the minute your pharyngeal phase starts, the very first thing that happens is your VP port closes. So that valve closes, okay? And the purpose of that valve is to keep food and liquids from going into nasopharynx. You also then, your oral cavity sort of gets closed off from the pharynx at that point once the bolus is out of it. Your vocal folds and your larynx close so that that valve is closed, right? And for a very short period of time, you have a closed system. So you have the VP port closed, you don't have access to the oral cavity, your vocal folds are closed, and so you have a closed, and your UES is closed for a very short period of time. Okay, all your valves are closed. You have a chamber that has no doors open. Well, at that same time, your base of tongue and your pharynx begins to contract and put pressure on the food because its job is to pump the food into the esophagus, right? And so simultaneously to like the mechanical movement, you have created a pressure chamber. The VP port has to stay closed, the larynx has to stay closed, and the UES, as the pressure increases, ideally should open and allow that pressure to relieve itself by pushing the bolus into the pharynx or into the esophagus. But I think that pressure system, we sometimes forget that the pressure system exists. Um, and I think that's where manometry really is the most helpful. I also think about it, you're going to see this little caricature as we go. Here's the one thing I would tell you. If you took physics in high school or undergrad and you were like, God bless, I never want to take that again. I'm really sorry. I'm about to bring like a physics principle in for just a second because I think this is the closest thing to like, so pull back in your spider webs, like what you learned in your physics class, because I'm going to talk about one of the like physics that sort of make this phenomenon and this idea of how pressure is generated um, make a little more sense. So if I said that the base of tongue was the pump in your swallow, right? Its job is to pump the liquid down through the esophagus. Then look at this picture right here. We have a pump that's trying to generate pressure to push water down a tube. That's not so dissimilar to your swallow, right? In a crude sort of analogy way, right? So you have a pump in the base of tongue that, when all things are working well, are going to push the bolus down into the esophagus. It's a pump and a tube system, right? Now, downstream from the pump that you see here is a valve, okay? If this valve on this animation is open, then the pump will push the water with whatever force the pump has able to push it with, and it will move in down the tube with no restriction, right? It will move down the tube with no impedance, with good admittance, right? It will admit the water all the way down the tube, okay? But what you're going to notice is that if the valve isn't working well, okay, so let's say this valve only stays open for a very short period of time, well, then the pump, no matter how good the pump works, the valve is going to restrict flow downstream, right? It's going to restrict the water from flowing through. Or let's say the valve stays open long enough, but it doesn't open all the way. It just opens a little bit, and so not as much water can be forced through it. Okay. Very similar phenomenon in swallowing, right? In that the pump is the base of tongue, the valve is the UES. And that's actually how you have to think about it in manometry. You have to think about it from a valve and chamber, a pump and valve kind of system to understand what manometry is giving you. Okay, so this is manometry. Okay, so if the base of tongue, if your pharynx is the pump, then this is the pump, right? Your contractility intervals are the pump. That's what's driving the push, okay? In contrast, here's a valve. So if your UES in a modified barium swallow study is the valve, and you need the UES to be open all the way, and you need it to stay open as long as you possibly can keep it open, or as long as it to let the bolus through, then that would be your valve, right? So that is looking at pressure and duration. Does it open all the way? Does it stay open long enough, right? Um, and then the where impedance comes in, and bear with me from a physics standpoint, where impedance comes in is how do those two work together? So if you have a pump and a valve, you also need to consider how they're working together. How is the pump pushing the water and how is the valve letting water out and how do they work together? That's where impedance comes in. Okay. And so impedance is really looking at how well does the bolus flow through the valve or through the UES. And when it's flowing through the UES, how much pressure are we having to generate up here, right? So this is Venturi's effect. If any of you remember your physics, the idea is that if a pump is pushing water through a tube, it can push at a steady rate to get the flow of the water to go, right? The minute it hits a constriction where the width of the tube narrows down, in order to keep the water from flowing, or to keep the water flowing the same speed and keep going through the tube at the same rate, what happens is the water speeds up and the pressure increases. Okay, so the minute you get a constriction, then you get a high pressure zone. So hear me out. A wide open UES has low pressure, long duration, and this pump is pushing against very little resistance. The minute the UES doesn't stay open long enough or doesn't open wide enough, then this pump is having to work really hard to push things through a stricture or like a constriction in the tube. That should get a lot more pressure up here. This is the beauty of manometry that I don't think you can really capture in anything else that we have. We are sort of limited to our visual analysis, and we make a lot of assumptions on how this works. But this is sort of the idea behind a pump and a valve system, and really trying to understand not only how does the pharynx work, like what's the strength of the pharynx, what's the contractility of the pharynx, and not only understanding how the UES works, but understanding the interplay between the two. That's the value of manometry right there. Okay. Every time I give a manometry talk, I cannot do it without talking about how the UES works because I think this is one of those things that, again, the variability in how it's taught in graduate school or any other like mode of understanding the UES, it's variable, right? And so I think in order to make sure that we all understand how the sphincter works, and because manometry is so important at understanding not only how it works, but how it influences the pharynx, we need to make sure that we all understand how it works. So we're going to take just a few minutes and review that, and then we'll go into case studies and I'll explain how, and you'll get to like see how manometry is applied. All right, so what is the UES? Well, first, it's a functional term. It's not one specific anatomical structure. I will say when I was in clinical leadership at the hospital, every time I asked this question to my like new hires, they would always say, it's just the cricopharyngeus. And I'm like, no. I'm like, that's one part of it. Yes. I was like, that muscle is important and it's in the UES, but the UES is actually a functional term where there's multiple structures working together to function as a sphincter. Okay, so we have multiple sphincters in our body. This is the one that we're going to talk about today. Really the only one that speech deals or swallowing deals with a lot. Um, there are parts of anatomy that are made up of it, but it's not just one single part. So you have your cartilages. Those are your rigid cartilages on the anterior side of your upper esophageal sphincter. Attached to those cartilages are muscles that make up your UES. So you have the inferior pharyngeal constrictor that attaches to the thyroid cartilage and sort of goes posterior and up a little bit, posterior and superior. That forms essentially the body of the piriform sinuses. Okay. You then have your cricopharyngeus, which most people do attribute to the UES. It absolutely is part of it. It's attached to the cricoid cartilage and then goes around. And then the other part that makes up the sphincter is your very first circular bands of the esophagus. Okay, not the whole esophagus, just the very top part of it. Those are the big structures that make up the sphincter. Now, I will tell you there's a vulnerable spot in this sphincter, and that is Killian's dehiscence. It's actually right here, midline between the cricopharyngeus and the inferior pharyngeal constrictors. So when we have muscles in this, they're set on top of one another. They're not intertwined like this to one another. And if there becomes too much pressure, so remember here I'm talking about pressure, then a lot of these vulnerable spots will become vulnerable. A lot of these spots will become vulnerable, like Killian's dehiscence, and that's actually sometimes the source of pathology at the UES. That's where the Zinker's diverticulum forms, things like that. So it would be really great, I think, if we all had the luxury of seeing our patients in these beautiful like hand drawings, because it's really easy to pick out the anatomy in this, but it's not that easy. And that's unfortunately not how we see our patients. We see our patients like this. So what I've done is I've tried to scale a modified barium swallow study to this anatomical drawing. Okay, so the first thing I would tell you is when you're going to find the UES, some clinicians are taught to find it by the C-spine. That is not the best way to find this. Okay, the best way to find your UES is actually to find it by your laryngeal cartilages because the muscles of the UES are attached to the laryngeal cartilages. Okay, and so instead of counting four, so vertical, like four vertebral bodies or five or however many you were taught, you should go find your cartilages. Okay, so for instance, in this picture, I think we could all see this is your epiglottis. Okay, this is your hyoid. Here's a thyroid cartilage. Okay, so if the thyroid cartilage is right here, which it is, do you see this? And we know that the inferior pharyngeal constrictors are attached on the posterior side of the thyroid cartilage, then your inferior pharyngeal constrictors are here and up. Okay, so here it is here it is here. Okay, we also need to go find the cricoid cartilage. That one's a little trickier to see oftentimes in your modified barium swallow study, but you can sometimes see the posterior horn of it down here. So when you look at your cricoid cartilage, it's thinner in the front and wider in the back. Okay, it's wider where the muscle attaches to it. Can y'all not see my cursor? I really feel like you can. Can you not? I'm on the screen. Can I make sure? Oh, good. Brooke can see it. I was like, I think my cursor's working. Cool. I was like, that would be really bummer if it wasn't. So when you go and look, you have, so thyroid cartilage, you have to go back and look. You can oftentimes more easily see the posterior part of your cricoid cartilage, which is right here, which means your cricopharyngeus is sitting down here. Now, I will say we're online, and so you don't have to rat yourself out, but I will say most clinicians that don't know that piece of information will have almost certainly put your UES up here, which is yes, if since the inferior pharyngeal constrictors are part of your UES, technically it is here, but it actually extends quite a bit of space. And so if you're making all your analysis of your UES up here, you're too high. Okay. And so you need to make sure you get down and actually look at where the muscles attach to the cartilage is. Okay. I also think it's really important um, to get very comfortable with the other view. Okay, so your AP view is really helpful. It's helpful in all swallows. It's in all parts of the swallow assessment. It's really helpful in UES assessment. But I do think if you're not used to doing it, sort of what you're looking at and where you identify the UES can be a little bit tricky. So what I've done is I've taken this picture that we just oriented ourselves and I turned the patient away from you. Okay, so the patient is looking away from us and you're looking at the back forward. So you can't see the cartilages anymore. They're hidden by the muscles, but this is what your AP view looks like. Okay, so your inferior pharyngeal constrictors are right here. Here's your piriform, here's your piriform sinus. You then have your cricopharyngeus that sits right here. Your circular bands sit just below that. And then Killian's dehiscence, which is that vulnerable spot in your UES, is right here at the midline between the cricopharyngeus and the inferior pharyngeal constrictors. I actually pulled an AP view out of a swallow study that had some contrast still in the swallow study because I think it makes it so much easier to see the structures when they're coded like this for like, unless this was a video. If this were a video, it'd be easy, but for a still shot, it has contrast just to highlight this. So what you can see here is here are your inferior pharyngeal constrictors, piriform sinus, piriform sinus. Here's your cricopharyngeus. Down here are your circular bands. If you had a Zinkers or anything pathologic form, Killian's dehiscence is right there. Okay, so I do think making sure that you can identify the UES in your imaging is important because I think oftentimes we try to associate with anatomical parts that it's not attached to, and it makes it a little bit more ambiguous than if you were to just attach it to the cartilages that it's supposed to be attached to and find your landmarks that way. Okay. So before I can talk through how it opens, we have to understand how it stays shut to understand how it works. So we have to understand how it stays at rest. So I think we probably all can like rattle off in our sleep that there's resting tone, right? The UES is closed at rest. I think all of us could probably say that have had dysphagia experience. I think the why behind it is a little harder, and sort of what exactly is causing that is a little harder to describe. But here's how that works. So first of all, both the inferior pharyngeal constrictor and the cricopharyngeus have tone at rest. Okay, now the cricopharyngeus contraction at rest is far greater than the inferior pharyngeal constrictors. But remember, they're both part of the sphincter, right? And the sphincter has tone at rest. It works together as one unit. But the cricopharyngeus has more pressure at rest, more tone at rest. It is closed and maintains that tone in two different ways. The first way is that it has active tone. So essentially there's continuous electrical activity sent to those muscles that tells it to maintain its tone. Okay. You then also have passive that are keeping that sphincter closed as well. Okay. So you have the elastic properties of the muscles. Muscles have properties of themselves, and probably more familiar to speech pathology are the mechanical factors that are keeping this thing closed. So remember I said you have these hard cartilaginous structures on the front end and you have muscles on the back. So the muscles are getting constant electrical activity sent from the brain to say stay tight. And these cartilaginous structures are situated in such a way that they're applying pressure from the anterior side when it's at rest to help keep that sphincter closed. Okay. Well, I do think a lot of people say, well, why does it even have to stay closed if it becomes a problem in swallowing and I ultimately have to evaluate and try to figure it out? Why does it have to stay closed? Well, I think we can't forget that one, its main purpose, or main two purposes really, are to protect from aspiration of reflux material. So it's kind of the last line of defense from reflux coming back up. And actually, there's reflexes in the esophagus that will increase the tone at the UES if it feels threat from below. Okay, so they have it documented pretty well that when there's reflux or something being threatened from below coming back up the esophagus, the UES tone will increase because it knows that it needs to be, it's the last line of defense before reflexes in the mouth. Okay. The other thing it does is it limits your swallowing or ingestion of air. So if I had a UES that was wide open, I will have likely ingested a lot of air, and then it's a constant belching through this entire presentation, which is unpleasant for all parties involved. And so the UES functions this way at rest for things unrelated to our swallowing. But we have to understand that because we have to understand how it's at rest because there's three things that have to happen for it to open. And unless you understand how it's resting, you won't understand how it opens. So the first thing is that neurologically mediated tone sent to the cricopharyngeus and the inferior pharyngeal constrictors has to be disinhibited. There has to be this neurologically mediated relaxation of the cricopharyngeus. Okay. That is mediated through the medulla and down through the vagus. Okay. You also need, remember I said there's passive parts of the swallow that are maintaining that UES sphincter shut, those being the cartilages on the front side of the sphincter, so your thyroid and your cricoid cartilage, okay? And so we need the entire larynx to move up and forward to physically pull the cartilages away from the sphincter, okay? And then the final thing that has to happen to get a good swallow is we need enough pressure to be generated in the pharynx that it will finally force the UES as open as it possibly can get and force the bolus through. Okay, so that is how the UES is, that's how the anatomy works, that's how it works at rest, that is how it opens. So let's talk for just a moment about how it's evaluated, and then we're going to go into some case studies on how manometry works with like the assessment of this. So this is just a reminder, right, is that we have a bunch of tools in our toolbox. We have a bunch of diagnostic options to get a good swallow evaluation. Today, we're talking about UES and manometry. I think even before you sat in this presentation, you would probably have agreed that the MBS is superior to the assessment of UES than FEES. FEES just can't get you that kind of information. But I will say it is pretty well accepted that fluoroscopy and manometry, and actually often the combination of the two, are the sort of the best way to assess this sphincter together. Because remember, the pharynx functions as a pump, the UES functions as a valve, and then we need to understand how the valve and the pump work together to let food through the UES into the esophagus. Okay. I think I'm gonna just remind you because I'm hopeful that you guys either do your own swallow studies. Maybe you were a student and had the luxury to get trained on MBS IMP as a student, or maybe you did as a professional. Maybe you use it in some sort of capacity. What I will say is I do think it affords us like a common language to speak. And I think the UES, the way they describe the UES, is a nice visual just like representation of how we interpret this. One of the things MBS IMP asks you to do when you are assessing the swallow is one, you first need to rule out any obstruction to flow. Okay, obstruction to flow being defined as something that needs to be medically or surgically intervened. Okay, so I'll show you. You guys have probably seen all these, but I'll just the one on the far left would be like a complete stricture. Okay, so there's nothing getting through the UES. That is a complete stricture at the upper esophageal sphincter on the far left. Another one you've probably seen a good amount is the one on the right. That's a CP bar, cricopharyngeal bar. I'll let you watch that one for just a second. So you see that cricopharyngeal bar. I will say I like this video a lot to remind you how far down the UES extends. Most people that associate it with the C-spine would have put the UES many vertebral bodies higher, but actually your cricopharyngeus sits off your cricoid cartilage, which for this patient is far lower than maybe you're used to seeing. Cricopharyngeal bar. Okay. Oftentimes cricopharyngeal bars, what you're going to appreciate is that it's really obstructive to flow right here. And it leaves a lot of the bolus in the pharynx. And this person's having to work really hard and generate a lot of pressure up here to try to push past a very tight narrowing. Cricopharyngeal bars are thought to be a precursor, if nothing is done to manage them, to Zinker's diverticulum, because you'll have pressure that's generated right here at Killian's dehiscence, which is a vulnerable spot just above the cricopharyngeus. Over time, the thought is that might be a precursor to something that looks like this, which is a Zinker's diverticulum. So you can see the cricopharyngeus is really sort of stretched out down here below the pocket. And then the final one that would be considered like an obstruction to flow that is needs to be medically or surgically managed would be an anterior cervical web, different than a cricopharyngeal bar, which is muscle down here. This is a web, which is sort of a scar band, thin mucosal scar band up higher, comes off the anterior side of the UES. So all of these are something you have to identify in your evaluation. It doesn't matter if you have manometry access or not. There's nothing that speech can do for that other than make the appropriate referrals. But that's not everybody, right? We see plenty of people that have no obstruction to flow, but still have abnormal UES opening. And that's where this manometry sort of fits a really nice gap that we have is when there's no obstruction to flow that needs to be medically or surgically managed, but the UES has either reduced distension, which means it doesn't open all the way, or it opens all the way, but maybe it doesn't open for as long as it's supposed to. That would be called like a duration or reduced duration of relaxation, right? The whole idea is that the UES opens all the way, so there's full distension of it, and it stays open long enough that the entire bolus can propel through and nothing be left in the piriform sinuses, right? Nothing be left. The whole tail of the bolus goes through. The UES doesn't close before the whole tail is through. If it closes too soon, then what it does is cut the tail of the bolus off and ship it back into the piriform sinuses. We see that a lot, right? And the question always sort of you have to ask yourself is why is it behaving this way? Okay. One of the things you need to consider is that the UES functions differently based on the volume and the viscosity of food that you consume. And so this sort of alludes back to this need for protocol, not just in your manometry so that we have norms, but also in your modified barium swallow study. I just want to show you, like this is one of the things you need to think when you see distension or duration issues in your UES on your modified. Is you need to think, could that be behaving in such a way because of what I asked the person to swallow? Okay. So what I want you to do is watch this first video. So she's going to swallow 3 times, I think 3. The first swallow is 5 ml of thins. The second is 5 ml of thins. And then the third is a 10 ml bolus of thin. So all I've done is increase the volume of it. I don't want you to look at anything in this swallow except the UES. And I want you to try to make a judgment, and then I'll tell you what I think too. But try to make a judgment. Do I think it distends all the way? And do I think it stays open long enough? Or does it shut too quickly and the tail of the bolus get shipped back into the piriforms? So just ask yourself that. Is it staying open long enough? And does it open all the way? Remember, just the UES. I'm going to pause it there. So those are both 5 cc's of thin. I would say it does not appear to fully open to me, and it doesn't appear to stay open long enough. And the reason I say that is I can see an indent, a prominence from the cricopharyngeal muscle on both of those swallows. I can also see that the tail of the bolus doesn't make it all the way through before the UES is closed enough to like leave, a good chunk of the bolus in the esophagus and put the tail of that bolus back in the piriforms. And so I think there's probably reduced distension and reduced duration on that swallow, but it's 5 cc a thin. Okay, this next one is 10 cc's, and I'm less worried, right? I see full distension. I see no tail left in the bolus. I think there's adequate duration of relaxation. Okay, so I think the swallow is fine. But you go back to thin. And so you just have to think to yourself, as you're working through this, like, what is the UES doing? Just be thoughtful on the influence what you're asking the person to swallow might be having on your interpretation. So let's say you're like, nope, I've given them small boluses, big boluses, heavy boluses, light boluses. The UES is not working. It is not distending all the way, and it is not staying open long enough. You have to begin to ask yourself, where's the problem? Well, the problem, there's only a couple ways it could not be opening, right? You just have to remind yourself, how is it supposed to open? Okay. If it's not, it's either there's not good relaxation of the cricopharyngeus, so that'd be like a neurologically mediated UES dysfunction. We see sometimes in medullary strokes. Okay. Or you have reduced superior and anterior hyolaryngeal movement that doesn't allow the mechanical removal of the cartilages that are sort of anterior movement of the cartilages that are holding that sphincter shut, or you don't have good pressure generation in the pharynx. Okay. So that's how you have to think about it, right? You have, once you're like, the UES isn't working, you have to begin to piece it apart. And this is where, pharyngeal manometry is really helpful. So I think the easiest way to like talk through pharyngeal manometry, especially if you're new to it, is to talk about it in case studies. And so what I'm going to do is I'm going to show you a modified barium swallow study, and I just want you to watch it. I want you to try to make a judgment call for yourself, okay? So I'm going to want you to try to try to figure out if you think the pump isn't working. So do you think this is a pharyngeal contractility issue? The pump is not driving, right? Do you think the valve's not working? Okay, so do you think this UES is not staying open long enough or not opening all the way? Okay? Or do you think, and then ask yourself, okay, how are these influencing one another? Is the pump and the valve working together to influence the flow of the liquid into the esophagus? Okay. All right. So I'm gonna let you watch the swallow study. Just just appreciate it. Just pump, valve, and how they work together. Try to come up with that kind of information. Okay. So before I show the manometry for this person, can someone like pop in the chat and tell me, do you think this is a pump problem, a valve problem, both? Like, tell me what you think. Do you think this is a pharyngeal contractility pumping problem or a UES problem? Like a valve problem? Yeah. Um, yeah, I see kind of both. Like I see some people say both, some people say pump, some people say UES. Initially, I thought the valve, but then saw some pump problems. Yeah. Okay. So this is where pharyngeal manometries are. I'll tell you, I'm going to show you the manometry and talk you through it. And then I'll like be vulnerable a minute and tell you this is my very first pharyngeal manometry. And I was like humbled. Um, Okay, so this is what her manometry looked like. Okay, so just to remind you from earlier in this slide, in the like discussion, blues are cool, right? That means they're low pressures. The higher the pressures, the more colorful, the more reds and oranges and things like that. So tell me, based on this, do you think there is a pump problem? Yeah. Do you think there's a UES problem? Right. So here's your pump. I actually didn't give you all the numbers because that tends to be really overwhelming. I just summarized them. And I essentially, what you're going to see as we go through these case studies is I'm going to orient it like pump, valve, and how they work together. So the pump, all your pharyngeal contractilities are abnormally low. That means you do not have enough pumping strength. You have a true pressure problem, a weakness problem in the pharynx, not driving things through. Okay. All of your valves were normal. Okay, so the way that you look at valving or the way the UES works in manometry is you're looking at two things. One is you're looking at how long it stays open. We call that UES relaxation time, sort of a surrogate or like a similar phenomenon to duration in your MBS. Like, does it stay long enough, right? And then UES minimum pressure, that is a manometric read of when it distends, does it distend on all the way, or is there some residual pressure left on the catheter? Because in theory, it should be fully open. The catheter should be not completely suspended in space, but largely suspended in space with very little pressure put onto it if you had adequate distension of your UES, right? And so what you can see here, I have a pump that's not working. I have a valve that actually opens all the way and stays open long enough. Okay. But I'm not getting enough admittance of bolus through into the esophagus, which when you think about it, that's why we have residual, right? That's all UES max admittance is trying to tell you. It's not able to tell you you have molecular residue, you have piriform residue. It's not able to tell you that. What it's able to tell you is there is a flow problem. The liquid is not moving into the UES efficiently, right? There is an admittance. It's not being admitted. Okay. Um, but I also don't have, I want to tell you about this hypopharyngeal intrabolus pressure. I want to allude to something really quick or like remind you about something. So look at this. Do you remember when we were talking about these physics principles? And I was like, I'm so sorry, I have to bring physics back into this discussion. I'm so sorry if you're traumatized. I'm traumatized by my physics in high school. It may be because I was in physics, like, I don't know. So I never thought I'd be dealing with physics again in my life, but so here I am. Um, so what you should look at this, right, is that if your pump is working and your UES isn't, then the pumped material or liquid that your pharynx is pushing, as it pushes through a poorly opening UES, you will build up a lot of pressure back here, right? Because it will be pushing against resistance. It's like you're pushing against a clogged straw, right? A clogged tube for all intents and purposes, right? So you'll get a lot of pressure right here. When we think about that from a swallowing standpoint, essentially what we're trying to get at with hypopharyngeal intrabolus pressure is when the fluid is flowing as readily as it can through the UES, what's the pressure just above the UES in the hypopharynx? How hard is the hypopharynx having to push to get liquid through it? Okay. If it's pushing excessive amounts of pressure, you would have a high intrabolus pressure in the hypopharynx, thus alluding to a possible UES dysfunction. Okay. But the fact that this UES is functioning normally and we don't have excess pressure in the pharynx makes you know that this is a pump problem, not a UES problem. Okay. It's important to know that, right? Because what we would do for a UES problem is very different than what we would do for a pumping problem, right? Like a pharyngeal weakness sort of problem. And so, pharyngeal manometry helps you really piece that apart. I will say, this is my very first pharyngeal manometry. Remember, I told you, like, we just went for it. Like, my providers and I just went for it. And actually, when they were like, yes, go, this case was the first one that I thought of because I couldn't. I'll give you a little. She was young, no medical diagnoses, came in for a swallow eval because she was complaining of dysphagia, presented like young, like in her 30s. And we sent her off to neuro to try to figure all of, we just couldn't figure it out. And I was like, she has no medical reason to have weakness. She has no medical reason. So because of like all the context clues of her age and no medical history and her cranial nerve exam, I did not think that I could not convince myself she was weak. Okay. And when you can't convince yourself that she's weak, then I thought, well, she seems to have some UES dysfunction, right? Like a piriform residue, the UES isn't staying open long enough. And so we brought her in for our very first manometry, and I was convinced we were going to find a UES dysfunction, and I did not. And I was like, what have I been doing? I was like, oh my gosh, I was mind blown because I don't think I had a good grasp on pressures and how they interplay with one another. And I think I had like overestimated my visual interpretation of swell studies. You know what I mean? Like I did what I always did. I used MBS IMP and I do all the things, right? And this was like an eye-opening. This was years ago when we first started doing it, but I always use her because it humbles me and reminds me how much I know now that I didn't know 5 or 6 years ago when we started doing this. And so this is an example of where that is a pharyngeal contractility strength problem, not a UES problem. Okay, I want to show you another case. I want you to watch this first swallow study. You can clearly see she's had a lot of hardware. I'll tell you about her case a little bit as we go. She actually had this done at an outside facility. She had a big ACDF and posterior approach to the spine surgery. And this was her swallow study immediately after this surgery, like post-op day 3 or 4, like right as they're trying to figure out if they can eat post-op. And this is what her swallow study looked like then. So just watch this swallow study for a second. And again, try to decide, is this a pump problem? Is this a UES problem? Or is this a both? Yeah. Okay. So Yeah, I think y'all both, like everyone is sort of saying the same thing. Like that looks like both of them, but I like the bolus isn't going anywhere. I can't really figure this out. I don't know. Maybe it's the hardware, maybe this. So I will tell you, she was like sent out and like did outpatient therapy. She actually like went from acute to rehab, rehab to outpatient. They had actually, as we do with our context clues, right? They had said, you had a huge spine surgery. Dysphagia is not uncommon after this spine surgery. We think this is related to the hardware. We think it's some weakness from the procedure. Like we're hoping as the swelling goes down and you begin to use the swallow a little bit more, this will improve. So they like proceeded on as this were mostly a pump problem, right? Like, yes, clearly there's UES, but they were hopeful the UES would improve as the swelling improved, as the pump improved, right? Like they were hopeful. So this next swallow study, I'm only gonna, you don't have to watch the whole thing, but with 46 therapy sessions later, she came back into my outpatient clinic, and she had 46 therapy sessions. So months, 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 months. And this is what her swallow looks like. Yeah, Melinda says the valve, maybe. Yeah, I don't think you have to see much to be like, oh, that's 46 therapy sessions and our swallow does not look that much different, other than bigger boluses were given. So we could like really try to cram stuff through there that the first swallow wasn't. Remember, bolus, what you're giving them matters when you're assessing the UES. And the first one was really small. So I think all of us kind of remained like, oh, maybe these are clearly not small. Yeah, Debbie says it looks worse. It actually isn't worse, Debbie. It is, well, I'm not going to say it is challenged more. It is provoked a little bit more than the first swallow study. The first swallow study, it was like 1 or 2 5 cc's a thin and nothing went through the UES. And so they kind of like aborted ship, right? The reason that one looks worse is because we also like proceeded to larger boluses under the understanding that certain bolus volumes and viscosities can be used in a safe but provocative manner to actually see what's going on. Um, so that is her. So tell me, do you think she's going to be a pump problem, a valve problem, or a both? She had a feeding tube, Daria. She was in PO. Yeah, I see valve both. Okay, I'm going to show you her modified. I mean, sorry, her manometry. Okay, so this is what her manometry looked like. Um, this is how her pump came out, which I think is really fascinating. It shows you that overall pharyngeal contractility is low. I think we would all know that. But what is interesting in this person is there is some retained velopharyngeal function. So she has the ability to close that valve off, but nothing overall, it still doesn't work. And your mesopharynx, which is your base of tongue region, and your hypopharynx do not contract well. Okay, so we have a pump problem, not all parts. It's like a fragmented pump problem, but we have a pumping problem. Okay. But look at this UES. Okay. We have essentially no relaxation at all. There's no drop in pressure. So the pressure remains abnormally high when it should have opened. And you have no drop in pressure to really be able to say that there's any relaxation of the UES, right? So we have a pump problem and a valve problem. Okay. And then when we think about how these are working together for her, the pump can't push bolus through, and the UES obstructs admittance, so nothing's being pushed through. This is actually has a little bit of contraction. It's not a contractile. So as it squeezes, it adds pressure and it has enough pressure that you have an abnormal amount of pressure built up in the pharynx because the UES doesn't open. So you have a very abnormal pump and valve that are essentially not allowing any bolus to go through. Okay, so unlike the one before where it was just a pump problem and the UES worked, this is a pump and a valve problem. And this is where you have to begin to sort of add your clinical assessment in with this. Um, So we actually did Botox. Our laryngology team that is a part of the development of this, Botox is cricopharyngeal dysfunction. We sent her for an MRI. We did a really good cranial nerve exam and realized that she has a vagus. Like she had palate was out, vocal fold was injured, blah blah blah. She ended up having a medullary stroke post-op that no one caught. And so she ended up having UES dysfunction and pharyngeal dysphagia from a medullary stroke that was sort of masked by the assumption it was just post-op dysphagia. And so this was a swallow study that we did right out 72 hours after Botox. And what you can see is that she still has pharyngeal dysphagia. She's going to. She has a medullary stroke. The pump is still going to be something we have to therapeutically work for her. I'm going to go up just a little bit. But the UES, watch how much better the valve is opening down here. That now we have the ability to work the pump, make the pump work more efficiently because we're not pushing up against a valve that won't relax, right? So she had truly neurologically mediated UES dysfunction that had to be mitigated so that she could respond to therapy effectively. All right, don't look at that one. I want you to watch this one. Just watch the swallow. Try to decide pump, valve, or both. He moves back. Sorry, that one's a little washed out. I apologize. I think it's the way I captured it off the you'll be, I mean, you can make judgment on it, but sorry, it's a little washed out. You're going to see a little pharyngeal diverticulum pop right here, transient pharyngeal diverticulum. Those are typically associated with pressure issues, pulsion types diverticulums um, between the inferior and the pharyngeal, um, between the inferior pharyngeal constrictor and the middle pharyngeal constrictor. Um, so that's what that is. That like is a red flag in your AP view of a pressure problem, right? We have a pressure problem if we have a vulnerable spot. That's actually the membrane that the superior laryngeal nerve comes into the larynx, and it in certain cases when the pressure is abnormal, you will have a diverticulum form there. It can be sort of a vulnerable spot, very similar like Killian's dehiscence, just higher up, and usually caused by something else. Okay, so some people say it's a pump and some people say it's a valve. Okay, I want you to tell me now, well, I'm not going to set it up that way. I'll just show you. Okay, look at this. Tell me, like, first glance, what does this look like to you? Like, what is unique about this one that is different from anything you've seen so far? Yes, Hannah. I love it. So do you see these pressures are so high? Now, be honest with yourself. When y'all said, and because I agree, like when you say there's a both, when you say there's a pump problem and a valve problem, when you're thinking about the pump, did you immediately go to weakness? Right? Did most people will initially think if there's a pump problem, it's a weakness problem, right? But actually, when you look at this, look at this. So his pump, all parameters came back abnormally high. So he doesn't have weakness in the pharynx. It is pumping abnormally, but not abnormally weak, abnormally hyperfunctional. Okay. So he has a lot of contraction. He actually has more contraction than we need to be efficiently swallowing. UES, though, does not open all the way, as evidenced by high minimum pressure. It also doesn't stay open long enough, as evidenced by low relaxation time or short relaxation time. Okay, so we have a pharyngeal swallow that's really high with a valve that's not opening well, okay? Which what that is ultimately resulting in is because the valve doesn't open, it doesn't matter how hard he contracts and how much extra pressure he's building up right here, he cannot push the bolus through there. It's not staying open long enough and distending well enough. Um, so this, tell me what you think that sort of picture looks like, right? Like I will say you shouldn't strengthen that swallow, right? And so I think that's where this pharyngeal contractility and like the use of pharyngeal manometry is really helpful, is because I think a lot of us make the assumption that um, pharyngeal problems tend to be weakness, and I think in many cases they are. But what this shows you is that we would be of no use to him. We would not help this situation at all if we sort of asked him to try to strengthen his swallow more to improve the UES, right? Because his swallow is abnormally high and pushing really hard against a UES that is not compliant with it. It's not opening like it needs to. Okay, we're gonna do with the high pressure be from yeah, Emily asked a question. You know, that phenomenon I don't think is well defined in our field. I think um I think if we used I think if we used pharyngeal, this is me on like my own anecdotal thoughts on muscle tension dysphagia. I don't think that we have a great definition for that. I think that if we used manometry to sort of flesh that out, I think maybe, but I think, just like other things, like I think if you have UES dysfunction, that you truly are confident it's UES dysfunction, then it's probably we have hyperfunction as a result of a dysfunction that needs to be medically managed, right? Not as like a muscle tension necessarily. And so I don't know. I think we need to better define that term, is sort of what I was going for. Emily, is like, I don't know that we have a great working definition of that to be able to say like he has it or he doesn't, because he clearly has UES issues too, right? I will say he came in post an ACDF. That was his complaint. So he had this ACDF that you see here that like is decently benign. I mean, like not benign. It's nothing's benign, but like it's not necessarily as complicated as the one you saw before. But he had residual dysphagia that he could not get over. Um, and so that's why manometry came in, because he was like, I shouldn't be having this symptom. Like his modified itself doesn't is not as impressive as some swallow studies we've seen, right? But his symptoms were so burdensome to him, which is why we dug a little bit deeper into that case. But you can see how pharyngeal manometry really helped us figure out like what isn't the right approach. Okay. And strengthening wouldn't be it. Okay, we're gonna do one more. And then we'll open for questions, or then I'll talk about a few things, and then I'll open for questions. So here's the final case study. I will say the view's a little funny in this because she's inpatient. She's in with a million aspiration pneumonias. She's inpatient, and so she's and very cachectic and all the things. But we essentially the team could not figure out why she was having so much dysphagia. But I want to show you just an example one other sort of pattern that we see. She'll lighten up. I feel like I pulled these off the server and they look kind of funny. Sorry about that. I think you see pharyngeal residue, if you can't tell. I think, you question if it's inefficient to some degree. I think most of us would probably question, because she's very cachectic and she's very weak and debilitated looking. She's been in with aspiration pneumonia a lot of times. I think most of would probably question if she has some sort of pharyngeal weakness contributing to that, right? She has some esophageal dysphagia as well. Someone asked about esophagus. In our practice, while we're talking about that, we actually run all pharyngeal manometries with an esophageal manometry, which is, we'll talk about that in a second, as I wrap up this presentation. But we have chosen, and our philosophy is that the system is one long tube. And so I think in order to like know that we have looked at the system in a holistic way. We actually do pharyngeal and esophageal manometry together. So what happens is they drop the catheter and they run the esophageal part. We pull the catheter back so it captures the pharynx. We run the pharyngeal part and then we decannulate, so that we can get a look at the entire system in one assessment. And so that allows us, and I'm not going into the esophageal part in these cases just for like the lack of time, but that is how we sort of look at all of them. I can't remember who asked that question, but that's how we incorporate the esophagus into a lot of this. Okay, so this is what her pharynx looked like. Tell me, pump, valve, both. What do you think? Yeah, so people are saying the pumps or both. Someone said the valve. Yeah. So here's how the pump came out. The pump has normal contractility. Okay. So the pump works normally from a contractility standpoint. Okay. But the valve, the UES, has short relaxation time and elevated pressure. So, and you can visually see that. Do you see how short this duration is compared to the other ones that we've seen? So the UES is not opening well up against a pharynx that is working fine. Okay. So what that ultimately results in is that your admittance through the UES is low because you're not able to, this doesn't stay open long enough and does not open wide enough to allow it through. And thus, even though this is contracting normally, it will build pressure up just above the UES because the UES is not compliant. It's not opening and allowing the bolus through efficiently. And so, actually, this is a case where the pharynx, we needed to do nothing from a strength standpoint. Okay. And we managed her UES. We Botox and dilated her UES. And then what happens is it opens longer, it opens wider. So she doesn't have the high pressure, she doesn't have the short duration. And thus, the pharynx that was normally working can then efficiently propel food through the esophagus. Okay. Just a few considerations while we wrap up, and then I'll answer as many questions as I possibly can. I'm hoping that those case studies sort of like showed how we can apply this clinically. So one, when if you were to decide that you want to like take the initiative to try to start something like this in your facility, here's some things that we had to consider, and we'll just talk through them. One is, do you want to do it with pharyngeal manometry alone, or do you want to pair it with your esophagus? I think different institutions do it differently. We at my institution do them combined. So we do an esophageal one, pull the catheter back, and do the pharynx. That was the choice. Remember, that was the choice of I'm using my GI physician's equipment, and they are esophagus docs, and they want to see the esophagus at the same time I want to see the pharynx. And we have an appreciation that it is one tube. It is one system that that interacts with one another. And so we feel like if we don't do both, then we potentially are going to miss something, and the catheter's already down. You know what I mean? The catheter's already placed. We have both speech and our medical techs. I already talked a little bit about this. Trained to place this catheter. That is an institutional policy and training process that you'll have to decide. Do you numb or do you not numb? That's like forever the question with anything that speech does with endoscopy, no different than fees, right? I will say this is an uncomfortable procedure when not numbed, but you do need to know, like, be judicious with the use of it, knowing that any sort of anesthesia that might impact pharyngeal swallowing will impact the outcome of this test for you. So we are very cautious with the use of our anesthesia. And we only use it when we absolutely have to, and we're pretty careful with it. And actually, to be in Texas, I can only speak for Texas. Speech can't administer anesthesia. So actually, our nurse does it. So that's that. The other thing you have to figure out is who you're going to partner with, right? So I partner with my GI team. and my laryngology team, but who else might you be able to partner with? And you're going to have to work through scheduling and interdepartmental collaboration. Um, I will say that that manometry in esophageal workup is still adjuvant to esophograms and endoscopy and things like that. It's always an additional. It is unusual, or at least in the practice in our esophagus team. I don't want to speak for every esophagus. It is. I cannot think of a time when my esophagus team would want only a manometry and not fluoroscopy and endoscopy or something to like kind of triangulate the findings. And I do think most people that are doing manometry do appreciate that it is unlikely to be a standalone swallowing assessment. It's likely to always remain as an adjunct to modifieds and fees. So it's not trying to replace anything that you guys are doing. It's trying to enhance the assessment of it. And then billing and documentation, that I will talk about in just a second as I go through common barriers. Billing is a problem and will probably be a problem. I mean, and as long as it remains a problem, will impact the viability of this going more wide. But so let's talk about some common barriers and solutions that we came up with, and that you probably are in your head thinking, right? So one of the common things we hear from clinicians, and we have it like literature has published on sort of this idea of like common complaints are access to equipment. Okay, these are very expensive. We know that speech doesn't oftentimes get the like really fancy, expensive budgets in these facilities that we kind of the little stepchild that sort of has to make it work with with very little, right? And so access to equipment can be a problem. Here's what I would tell you about that is one, we worked around that by collaborating with our GI doctor that already did it. They typically, if they want to know their machine's protected, they want to make sure that it's not like mishandled, it's expensive, they're funding it. But what has really been nice about that is they manage the equipment, they manage the processing of the scopes, they manage the maintenance, and so while there are some companies that are cheaper than other companies to buy manometry equipment for the speech department or whatever department you're in on your own, you're welcome to. Um, it's fiscally a little bit more resourceful if you have access to some other provider that's also using it, because they're not using it all day, every day. You know what I mean? Like there's the way we're doing it. We have actually 3 manometry towers that rotate through like 8 physicians because they have blocks. And so I have Thursday morning blocks. Thursday morning, they know that one of those machines is a pharyngeal machine, because they run their anal manometries and their esophageal manometries and all the other things like other blocks in the day. And so we just worked through our schedules and stuff and the processes to allow us to share equipment. So that's always a possibility. I think the other thing that tends to be a complaint is this billing and coding problem. Yeah, so the bigger, like if you are in a job um that is looking at your productivity and what you're billing and things like that, yeah, we unfortunately do not have a code other than the clinical swallow eval. If you're using it for a diagnostic procedure, that you can bill for this. Now, there's a professional code that your GI doc can overread or your laryngology can overread and bill a professional code too, and then a facility fee if you do it as an outpatient. But I will say, until we can like as we continue to advocate for billing, I do think that getting a dedicated billing code for speech pathology is going to be beneficial for clinical viability long term for us, because right now we just don't get paid. We don't get reimbursed for this procedure for the amount of like work the analysis takes on the back end. And so um that is one thing. It's being advocated for us to have some, people advocate at all sorts of levels to try to get this funded, but right now your only option is that. Um, I would say sort of another group of complaints we sometimes get is this idea of like, we don't know enough about it, right? Like there's limited published literature. So here's what I tell you, there's ongoing research. Actually, you're probably in a period of time right now that's having more than it ever has on pharyngeal manometry. It really has gained a lot of traction. But here's what I would tell you. If you are considering using it right now while we're still building the research base on its utility, I think there's several things you have to consider. One is the successes and the areas of improvement will be identified as we clinically use it, right? The use of it can then be, and like the wins and the losses and the challenges and the barriers and the benefits all can be shared amongst providers to continue to improve it and streamline it as time goes. So, um, the other thing I would tell you is if you choose to be an early adopter of pharyngeal manometry, what I would really encourage you to do is remain well read on the growing literature base. I will tell you, so we started doing it, like I said, in right around COVID, so whatever, 6 years ago. Like things have changed even in that period of time. And so I think if you're going to be on the early end of this, which I do think the clinical utility needs some people to be willing to like get out there and do it, you really need to stay well read on it because you're going to change your patterns, change your protocols, change your analysis as we continue to learn more. We just had like when I first started, I was working on a protocol from like a 2020 manuscript, and then in 2025 another one came out and I changed my protocol, right? Because it wasn't like throw it in the trash, it was just like tweak it a little bit to be able to use it with like the new literature that supports it. And so that's all I would tell you is like constantly be well read on it because I think early adopters are going to have to be flexible and stay in the know to like keep up with this like rapidly evolving use of it. And then this is probably the final one that tends to sort of like stick people is this idea of like, I don't even see how I could get this clinically in my workflow, right? Like, I don't even understand how I can clinically integrate this. Most commonly people cite the like time required to analyze this, the integration, like I don't understand how I already have modifieds and fees. I don't see what this is going to give me. I also think like the inevitable pressures of productivity in big facilities or even small, like in healthcare in general, right? So if they are time consuming, plus our billing code's not super favorable, plus there's like you're unsure of like how it adds to your clinical decision making, that tends to make people feel not quite as empowered to figure out how to integrate it into your clinical workflow. Um, but, it sort of alludes back to one, it's not replacing MBS and fees. It's really adding to enhancing the evaluation procedure for your patients. And yeah, unfortunately, it's going to be time consuming at the front end. I will say the more you do, the faster you get at it. Analysis can be done a couple different ways. There's manual analysis of it with like the Medtronic system. And then there are cloud-based analysis softwares that some places use too, that you can upload your file. Clearly, if you can upload your file, the analysis is far less time-consuming and tedious. But regardless of which way you do it, even if you have to or choose to manually mark, like manually analyze it, the more you do, just like anything else, the faster you get at it. And so stick to it. It's going to be very time consuming on the front end, and the better you get at it, the more efficient you get at it. Um, okay, and then just to sort of wrap it up as we like lead to questions, I hope that I've communicated that manometry is an entirely different way of thinking about swallowing than most of us were trained or are used to doing. It can be really beneficial in getting a better understanding of the oral pharyngeal swallow, the UES, and then how those two interplay with one another. Um, we do think that it's beneficial when you need more information. But it takes a team and building relationships with other providers that will support manometry and that potentially have access to the manometry equipment is really important. You cannot do this one alone. It's not so dissimilar to modifieds, right? Like you have to have radiology staff to perform those. Manometry is no different. It's just not your radiology staff. It's your GI staff or your, GI lab staff or wherever you place this. And so it's definitely, it has really it has stretched my mind in ways as a clinician, it has stretched my mind in ways and made me understand swallowing in ways that I didn't before. Do I do it on every patient? No. I do it on the ones, like I said, where I need more information, where I think I don't understand what's happening here and I need more. Um, I did not send in a handout. I'm happy to send handouts. There's my contact information if you want to email me, I'm happy to send handouts. I also am happy to send, if you want a full reference list, I like shorthanded the references on the slides. But if you're like, I really want to see where she got that reference, I'm happy to send a full reference list. If you'll just shoot me an email to that, I'm happy to do it. Okay, well, I am gonna hand it over to Brooke. Brooke's gonna like orchestrate our question and answer time, but before, like, in case people are gonna jump off, one, I appreciate your time. I know it's late in where some people are staying. I appreciate you coming on and letting me talk to you about this, and I hope it was helpful.
Awesome. Thanks, Diane. So we did have a lot of questions, so I'll try to get through some of the top asked questions. The first one is, what are your recommendations or guidelines for an SLP who wants to implement high resolution pharyngeal manometry within their scope of practice? And do you think a physician should be present?
Yeah. Okay, so I can just tell you how we do it. So the patient comes in and they check into the GI lab. The GI labs where like endoscopies and peg placements and all the things and bronchs and all the things happen. They're ambulatory. We do 95% of ours in an ambulatory setting. We don't often go inpatient unless we specifically need to. So the patient comes in, they check in for a day procedure, just like you would any other. The nurse numbs for the esophagus part. The GI lab tech has been trained in manometry will place the catheter and they'll run the esophageal part. And then they call me and they're like, hey, Diane, we're ready. And I'm like, great. And I walk in, I pull the catheter back a little bit, like just the number of centimeters to get the pharynx in view, because for the esophagus, they drop it pretty low. I pull it back, I run my swallows. If she's there, she'll decannulate. Oftentimes she's not there, and I'll just finish up the study and pull it and decannulate it. Um, so that's how we do it. I think the question also alluded to like scope of practice. So, what's interesting about that is one, I definitely think it depends by state, but I also think there's some things like that that are considered sort of like not shared responsibility, but like if you're trained and have competency in it and have been like trained and proven competent and your facility has like a structured competency, then you can oftentimes do that in a very safe and like supported manner. So the way we do it is like a physician is not physically present in there, but like when we were training on placement, they were present, right? And then they saw X number for us. And then once were proved that we were competent to place it, then they sign off the like facility competency checklist that says like, yes, she can do this procedure for us. Um, the other person that does it, if this gives you any perspective, is a medical tech who doesn't have to have a degree. So I think you also have to think about like in the big picture of things, like they learn, honestly, we can place these so much easier than they can. And it's all about like logistical compliance stuff because it makes no sense that a medical tech who doesn't actually have to have a degree can do it, but we can't as long as we follow like whatever competency system you have set up. Yeah.
This next question is along those same lines. This person asked, are there restrictions that you know of by state for passing a catheter into the esophagus?
Uh, I don't know that by state. I live in Texas, and like I said, our compliance people at my facility essentially we're fine as long as the physician trained and like signed off on my competency for it. But I'm in Texas, so and it's my facility's like driven compliance policy. So I would say you might check. Um, Honestly, the best thing to do is to check who's dropping your esophageal manometry now and then like talk to them about the compliance process and all of that kind of stuff for your institution. Because whatever state you're in I can't speak to that. I don't know. I'm sorry.
Um, that's okay. This next question is about billing. This person said,
Uh,
do you get pushback for billing a CSE if performed after a modified?
yeah. So we actually don't do them on the same day, because the person has to be, okay, yes, I should tell you this. We don't do the modified on the same day as the manometry, um, mostly because the person has to be NPO. When we combine our pharyngeal, well, any of them, they have to be NPO going into that procedure for us. And so I can't put the modified before it. And then that procedure is not that fun. And so I often find that they are also not interested in like staying and continuing on the process. And so we oftentimes do it either the day before or the day after. Um, and not the same day. So we don't have billing issues because we changed the days on it. So yeah.
There were quite a few questions about references. So Diane mentioned that she's happy to provide her list of references. And there were a lot of questions about the cases. So we'll just take one. This person said, for your case where you had a female patient with an ACDF, what showed you that she needed Botox versus a myotomy, and who would complete it, GI or ENT?
You get such a you ask a good question on like here's the thing. And actually I have a systematic review that's about to be published on this same phenomenon in that it's the wild wild west on when people Botox versus myotomy. So the reason we knew she needed some sort of neurologically mediated intervention, whether we knew she had a medullary stroke. We knew she had a high vagal injury. Like she had a palate out, a vocal fold out, a hemipharynx out, a UES was out, right? Like we knew this was a neurologically mediated dysfunction. And we knew that the intervention for that was Botox if you don't want to myotomy it. Okay. Most there it's kind of wild wild west. Some physicians will go straight to a myotomy. The risk with that, at least my physicians express risk with that, is that there's no going back once you do that, right? And so if you cut it and let's say they have reflux, or let's say they have like unmanaged reflux, or they have something where that UES needs to still have the ability to work to some degree, or then they tend to want to do the first line attempt at Botox because it wears off, right? With if you aren't consistently most of the time you have to Botox and do therapy on top of one another. If you Botox alone, it doesn't stick. Like the you need to also fix the pump after you open the UES on those kinds of cases. And so, but they're a little reserved, at least in my experience with any laryngologist, is they would rather see if that actually fixes the problem before they're willing to cut it. If Botox fixes it, and while the Botox is working, the patient's US works fine, and then as it wears off, they have to ultimately go back to Botox and back to Botox repeatedly, then that's when sometimes they'll consider a myotomy long term once they've proven that deinnervation of the UES works for this particular patient. Hope that's helpful.
Yeah. Well, in just respect of everyone's time, we will wrap up. I know we did not get to all of the questions, but Diane is kind enough to provide her contact information. A couple of housekeeping items. Again, this session was eligible for 2 ASHA CEUs or excuse me, zero point 0.2 ASHA CEUs or 2 PDHs. If you'd like ASHA CEUs, please fill out the survey that was in the chat. It'll also be sent out via email from Zoom. And then if you'd like a certificate of completion, send us an email at tims-univ@tims.com. And this webinar will be up on the TIMS website within 24 to 48 hours. With that, I want to thank Diane for offering her expertise with us this evening, and thank you all so much for joining us. Bye, everybody.
Thank you.